Treatment of alcohol and drug dependence. Drugs have been used since time immemorial, mainly to get relief from the stress and strain of life and for ritual purposes. Historical evidences suggest that people have been using cannabis for 8,000 years. It was used by many early civilizations as medicines for anxiety to digestive problems. About 600 years ago, ancient Sumerian texts considered poppy plant, from where opium is produced, a joy plant. There is mention in the ancient books of the old Hindu medicine for chronic alcoholism and even delirium tremens. The Aryan invaders of India used a beverage called somaras. The Aryans knew the narcotic and euphoric properties of the cannabis plant thousands of years ago, and there is little doubt that they made use of these substances. Buddhism in India contributed much to the habit of sobriety among the masses. Since 2,500 years, the native of South America chewed coca leaves to derive pleasure and relaxation. Greek hero had to face the mutiny of his followers because of the lotus plant, as mentioned by Tennyson in his poem The Lotus Eaters. The lotus is a cactus plant that contains mescaline, a hallucinogen. In the medieval times, the kings and the aristocrats took to drink, and by their example, the habit spread among the masses to some extent. Alauddin Khilji, who imposed total prohibition, and Aurangzeb, who practiced strict abstinence, were the exceptions in their times. It is to be pointed out that for the whole of the pre-British period, the masses in general remained free from the effects of drinking and taking drugs. The British administration attempted to derive regular revenue from the sale of drinks and drugs. The government in the year 1790 enacted excise laws for taxation purpose, and excise departments were established in all the provinces. Their policy was maximum revenue with the minimum consumption. The first inquiry into the prevalence of the drug addiction of opium and cannabis was made 100 years ago, when the government of India appointed two commissions in 1893 and 1895. In 1954-55, a prohibition inquiry committee was appointed, and the committee recommended complete prohibition in the country to be enforced in stages. The enforcement was to proceed on two lines: educative and preventive, and legal and administrative. A prohibition study team was appointed in 1963 to go into the problem and report to the government to the present position regarding alcoholic drinks and alcoholics in the country. The team recommended awareness building, modern treatment programs, public education on alcoholism, training of NGOs, and research in prohibiting. India, which not so long ago was known as a country for the transit of illicit drugs from Golden Triangle and Golden Crescent areas, is now turning into a consumer country. According to Narcotic Control Bureau figures, the annual heroin seizures in the country are about 1 ton. Alcohol and drug dependence is a serious disease that affects the health and well-being of millions of Indians. Treatment refers to a broad range of services, including identification, intervention, assessment, diagnosis, counseling, medical service, psychiatric services, psychological services, social services, and follow-ups for persons with alcohol and drug dependence. The components of treatment include management of withdrawal, long-term management of alcohol and dependence, and prevention of relapse. A number of alternative treatments are available for alcohol and drug dependence, ranging from pharmacological therapy to counseling, marital therapy, and family therapy. Frequently, 2 or more treatment modalities are combined in one therapeutic approach. Here, we will be having a brief overview of currently used methods and approaches in the treatment of alcohol and drug dependence. Most of the treatment modalities are of Western origin, particularly for the United States of America. Treatment stages. Drawing on the various approaches which have attempted to treat the addict, we can divide them into 3 major stages, namely intervention, rehabilitation, and maintenance. The stages incorporate the commonly used activities and phase that have been identified by various researchers and practitioners all over the world. All treatment modalities will have the following objectives: recognition of the problem, understanding of the disease of addiction, acceptance of other inputs, personal responsibility for recovery as opposed to blame, demonstration of new behavior and attitudes, developing a new healthy daily pattern of living. James Prochaska and his team from the University of Rhode Island have come up with an excellent model to explain how people change, because addiction treatment is basically a process of change. The first stage is pre-contemplation. This is the denial stage, which we described earlier, where other people except the addict realize that something is wrong. Here the emphasis that though the addict is not accepting change, he is somehow on the path of change. The second stage is called contemplation stage. At this stage, the addict realizes that something is going wrong, but he is not sure what is to be done about it. The third is preparation stage. At this stage, the alcoholic takes concrete steps towards change. The fourth stage is called action plan. At this stage, the person puts his heart into change and makes personal commitment. The fifth stage is known as maintenance phase, which is the crucial one in the treatment of addiction. Change is not something that happens only once, but something that is ongoing. The sixth and the final stage is termination phase, the compulsion to use lessons. This description emphasizes the fact that addiction is a process that is ongoing and addict has to continue to recover. Intervention. All the sick people in the world would long for recovery. The addict also longs for recovery, but he will not go for treatment because he believes that the other people caused his illness and they need treatment. To get a person off the drugs, we need to motivate him for treatment. The first step is motivating the addict is called intervention. The first step in intervention is the identification by the person seeking treatment or another individual, whether a family member, supervisor, or law enforcement or medical professional, of the existence of a problem with the alcohol or drug dependence, followed by referral for treatment. Intervention with chemically dependent individual is an important step in the direction of treating one of the most widespread disease in our culture. Knowledgeable and caring persons around the abuser who come together with a trained interventionist who will motivate the group and show them how to present their accumulated data to the alcoholic in a compassionate way. Also know this as confrontation. It is a process by which the harmful, progressive, and destructive effect of chemical dependency are interrupted, and chemically dependent person is helped to stop using mood-altering chemicals and to develop healthier ways of coping with his or her needs and problems. It implies that the person need to not be an emotional or physical whack or hit bottom before such help can be given. The goal of the intervention is to break down those defenses so that reality can shine through long enough for the person to accept it. It is a way of presenting reality to a person out of touch with it in a receivable way. By presenting reality, we mean presenting specific facts about the person's behavior and the things that have happened because of it. A receivable way is one that the person cannot resist because it is objective, unequivocal, non-judgmental, and caring. An intervention is a confrontation, but it differs in some way very important respects from the sort of confrontation with which most people are familiar and which have little or no positive effects. The first step is to get a team ready for intervention. A team consisting of 2 or more persons who are close to the chemically dependent and have witnessed his or her behavior while under the influence should conduct the intervention. The chemically dependent person's defense system are far too highly developed to be breached by one person acting alone. If the person is married, the wife or husband should be at the top of the list. The other person to be included in the list are immediate supervisors, parents, children, close friends or neighbors, co-workers, a significant member of the religious community, and an addiction counselor if available. The second step in the intervention is gathering the data. There are 2 types of data to be compiled in preparation for the intervention: facts about the victim's drinking or using behavior and information about treatment options. The third step is the rehearsing of the intervention scene. Usually 1 or 2 rehearsals prior to the actual intervention are held. Everyone who will be at the intervention, with the exception of the chemically dependent person, should attend these. Each member of the intervention team should come prepared with his or her written list of facts about the chemical dependent person's behavior. The fourth step of intervention is to present the data to the addict in a compassionate way. For example, you were abusive to your colleagues at the factory on 15th March and again on the 20th March. In both instances, alcohol was detected in your breath. It is important for the group to remember that they have not gathered to debate the issue with the addict, but to confront the problem and persuade the person to treatment. When the above 3 steps are completed, you are ready for the intervention. In the intervention, the victim is offered specific choices by the treatment center or the hospital. Usually the chemically dependent person refuses to consider either of the choice and vows to quit drinking of his own. Then the treatment team would present the what if question. What if you start drinking again? What if you have just one more drink? The team would make an agreement with the chemically dependent that he or she would accept help. When the chemically dependent agrees to accept help, it is made available immediately. The first stage of treatment offers is called detoxification. Detoxification, it is the management of acute alcohol or drug intoxication and withdrawal while in either independent living or in a sheltered living environment. This is the medical process of taking the affected person safely through the predictable sequence of symptoms that occur when blood, alcohol, other chemical level drop during withdrawal. Alcohol withdrawal symptom ranges from a trivial to the markedly unpleasant and life-threatening reactions like the delirium, tremors, or withdrawal fits. A patient suffering from the dependence syndrome may therefore require immediate specialized medical assistance in coming out of alcohol. This may be accomplished with a general practitioner's help as an outpatient basis if social support is available. But severe dependence is sometimes an indication for hospital admission so that careful observation can be provided and intensive nursing and medical care are on hand. Detoxification is not designed to address the psychological, social and behavioral problems associated with addiction and therefore does not typically produce lasting behavioral and attitudinal changes necessary for recovery. A variety of drugs may be used to provide treatment for withdrawal and specifically skilled nursing care is needed for the delirium and agitated patient. Modern methods of care are very successful in treating this acute phase of the problem and risk to life have been much reduced. The Development Detoxification Center over the last few years has shown that alcohol dependence can be safely and effectively helped to overcome withdrawal symptoms. Detoxification can usually be achieved in a non-medical setting provided medical service is readily available when necessary. Stage 2. Rehabilitation. This stage of treatment consists of 3 components: evaluation and assessment, diagnosis, and maintenance. Stage 2. Rehabilitation. Evaluation and assessment. The development of an individual treatment strategy aims at eliminating or reducing alcohol or drug consumption by a thorough assessment of person's physical, psychological and social status and a determination of the environmental forces that contribute to the drinking behavior. Evaluation and assessment is done by screening, which is the use of easily and inexpensively administered procedure in an attempt to establish the presence, absence, or degree of severity of a condition. It currently is undertaken for many physical and psychiatric disorders. Diagnosis is the confirmation of the nature of circumstances of a condition. It is usually accompanied by recommendations for intervention and treatment. Screening is an important preliminary step in the diagnosis of alcohol use disorder. It is needed to ensure the early identification of individuals who have begun to develop or are at risk of developing alcohol use problems. Screening tests serve to direct these individuals towards further assessment, which may include medical or psychiatric history, physical and psychiatric examination. Based on the assessment, a diagnosis is confirmed or refuted according to prevailing criteria. Screening methods include questionnaire and interviews for assessing psychosocial indicators of alcohol problems and laboratory tests and other biological measures for detecting biochemical markers of excessive drinking. Screening questionnaires are often self-administered. Screening instruments typically do not provide information that is useful in selecting treatment program and specifying treatment goals, whereas the more complex questionnaire and interview collect richer information and permit more detailed evaluation of patient with regard to treatment planning. Many traditional screening questionnaires ask questions in ever terms to determine the presence or absence of symptom. Other screening instruments require subject to indicate present state, habits, behavior, and feeling. Each type has advantage and limitation. The CAGE questionnaire is a simple method and can be easily administered. It uses a 4-item instrument to detect the symptom or problem. They are: have you ever felt you should cut down on your drinking? Have people annoyed you by criticizing your drinking? Have you ever felt bad or guilty about your drinking? Have you ever had a drink first thing in the morning to steady your nerves or to get rid of hangover? Eye opener. One yes response raises suspicions of an alcohol use problem, and more than one is strong indication that a problem exists. CAGE takes only 30 seconds to administer. When included as part of a routine health screening, it may detect alcohol use problem that might be missed otherwise. Primary care. It is the application of therapeutic activities to help the individual reduce alcohol or drug consumption and attain a higher level of physical, psychological, and social functioning while in either independent living or in a sheltered living environment. Extended care, that is stabilization. It is the consolidation of gains achieved in primary care through continued participation in the treatment and supportive activities, while in either independent living or in transitional supportive sheltering living environment. Stage 3, maintenance. This stage consists of 3 components: aftercare, relapse prevention, domiciliary care. Aftercare. It is continued provision of some therapeutic inputs to maintain the gains in functioning achieved through intensive intervention and stabilization while in either independent living or in a transitional or long-term supportive shelter living environment. Relapse prevention is the continued provision of therapeutic activities to avoid the return to prior patterns of drinking and to maintain the gains in functioning achieved through brief intervention or intensive intervention and stabilization while in either independent living or in transitional or long-term supportive sheltered living environment. Relapse prevention believes that patients with more severe type of drinking and drug abuse should be offered continuing contact with the helping agency, at least for the first year or 2 after commencing treatment. Drinking and drug abuse problems of any severity are never resolved overnight. A patient's great awareness of problems often evolves slowly, and the wish for help may similarly evolve. Relapse is inevitable for most of the addicts. Some sort of continued availability on the part of the helper and an assurance to get patient that someone will continue to be interested is therefore often indicated. A regular reminder that the venture is worthwhile and the repeated instillation of hope at times of despair and crisis are both invaluable ingredients of effective therapy. Relapses will most often occur within the first few months of therapy. Neither the addict nor the family should regard these as catastrophic, provided they are attended to promptly and continued contact with the treatment agency is maintained. They should, however, be taken seriously and viewed as an opportunity for enhanced self-understanding and appreciation of the precipitants involved. Many relapse occurs in response to deeply felt emotions and anxiety or interpersonal stress or from an inability to withstand environmental pressure to drink. Patients who have carefully rehearsed a repertoire or technique for coping with these pressure have better chance of avoiding relapse. It also helps if the likely consequences of relapse can be vividly retained in the patient's mind, as this seems to offset the understandable temptation to think only of the short-term benefits which might follow a return to former habits. For example, Shekhar recognized that relapse commonly occurred on paydays. He planned ways of avoiding this critical series of events. He would arrange to visit a friend who knew of his drinking problem on the eve of payday. If the anxiety became worse, he was encouraged to phone to a friend or counselor and talk about how he was feeling. Along with these measures, he also retained a vivid mental imagery of himself lying on the road, unable to get up, his dress stained with vomit. These were, of course, short-term psychological devices and helped him to cope in the first few months of abstinence, while he effected more lasting changes in his way of life. In recent years, relapse prevention strategies have been widely publicized and training has been offered to practitioners. The addition of relapse prevention procedures to a treatment program is intended to reduce the probability of relapses. Although the techniques can be used for primary rehabilitation as well as relapse, the self-efficacy approach, behavioral treatment strategy derived from Bandura's social learning theory of self-efficacy, behavioral self-control training, and cue therapy are described below as example of these techniques. The self-efficacy treatment strategy use careful assessment of the situations in which the person drank heavily or abused drug during the past year to determine which contexts present a high risk or return to excessive drinking or drug abuse. This approach also involves careful assessment of the person's confidence in his or her ability to handle conflicting or stressful situations without resorting to heavy drinking or drug abuse. The key assumption underlying this strategy is that drinking or drug abuse alone does not lead to a return to chronic excessive drinking or drug dependence. We need to take into consideration the meaning of the act of drinking or drug abuse for the person, the alternative behavior that the person has available for coping with the stressful drinking or drug dependent situation, and the strength of the individual's belief in his or her ability to handle the situations effectively without restoring to drinking drug abuse. Treatment consists of developing a hierarchical series of performance-based homework assignment that the person can perform successfully, thereby experiencing a sense of mastery in what were formerly seen as a problematic drinking and drug abuse situations. The therapist monitors the person's feeling of self-efficacy as each assignment is completed. A variety of techniques can be used, including rehearsal of the activity during the therapy session and joint performance of the task with a responsible friend or the therapist. During the treatment process, the person may also use an alcohol sensitizing drug as additional protection. Behavioral self-control training is another relapse prevention strategy that uses a set of self-management procedures designed to help individuals stop to or reduce alcohol or drug consumption. Treatment using this modality involves self-observation or dependency behavior through self-monitoring and the setting of specific behavioral objectives based on analysis of the functioning served by drinking or drug abuse, roughly categorized as drug abuse to cope and for pleasure. The self-monitoring of drinking behavior through the use of structured record keeping provides information both about the function of drug abuse and situation of high risk. Self-monitoring also provides feedback about progress. For persons who use drink or drug for coping, treatment involves the establishment of alternative cognitive and behavioral responses. For persons who use drug and drinking for pleasure, treatment involves the establishment of self-control skills to avoid intoxicating and the development of alternative recreational skills. Cue therapy consists of a series of treatment sessions in which the person is presented with the sight and smell of alcohol, but consumption is strictly forbidden after the person has imagined himself as a high-risk situation for drinking. Example, having a fight with their spouse or attending a party. The person and therapist then review the feeling aroused by the alcohol and may practice response that can lead to refusing a drinking. Cue therapy is based on extinction theory. The cues lose their arousal value through repeated exposure without reinforcement. Domiciliary care. It is the provision, protected and ongoing supportive protection living environment for those who too disabled by prior alcohol drug use to return to independent community living. This situation is warranted for those who are physically unable to lead community life due to illness or other disability. Goals of treatment: give up the dependence on drugs to handle daily problems, improve relationship with others, improve ability to handle problems, improved physical health, handle effectively employment issues, deal with legal issues, improve overall quality of life. Treatment settings. The term treatment setting is used different ways in the literature on the treatment of alcohol and drug dependence problems. Sometimes it is used to describe the organizational location in which treatment is provided. Treatment modalities include 6 categories: pharmacological, social, psychological, behavioral, psychodynamics, and spiritual. The major distinctions have been in terms of drug used to counter and antagonize the acute effects of alcohol and drug intoxication, drug used in the management of withdrawal, and drug used in long-term treatment, rehabilitation, and relapse prevention. Since the purpose of this is only to provide the minimum requirement and useful information of the treatment, we shall not be discussing the aspect of treatment. Social treatment modalities include marital and family therapy, women's group, Alcoholics Anonymous, AI ANON and AI 18, Employee Assistance Program, Narcotic Farms, Therapeutic Communities. Psychological treatment modalities include behavioral treatment modalities, chemical aversion, covert sensitization, stress management training, social skills training, contingency management, community reinforcement counseling, harm reduction, controlled drinking. Psychodynamic treatment modalities include individual psychotherapy, group psychotherapy, group dynamics, activity groups. Spiritual treatment modalities include yoga and other spiritual activities. Scheme for prevention of alcoholism and substance abuse. The various schemes financially assisted by the ministry are the following: first, awareness and preventive education; second, drug awareness and counseling centers; third, treatment cum rehabilitation centers; fourth, workplace prevention program; fifth, de-addiction camps; sixth, NGO forum for drug abuse prevention; seventh, innovative intervention to strengthen community-based rehabilitation; eighth, technical exchange and manpower development programs; and ninth, survey, studies, evaluation, and research on the subject covered under the scheme.